Hello everyone, I am Ana Samira Pangkatan Ali from Group 1 and today I'll be discussing about alternative clinical trial designs for our Research 2 subject. Thanks to the efforts of my group mates, Drs. Akad, Acelo, Alcular, Almohalas, Ampatuan, Amerol, Animas, Aniversario, and Dr. Armada. And under this alternative clinical trial designs, we'll specifically be tackling factorial design, cluster randomization, active control trials, adaptive designs, non-randomized between group designs, and within group designs. First, we have the factorial design, which is a randomized trial that tests at least two independent interventions simultaneously, allowing researchers to answer multiple questions in one study. For example, in a heart failure trial, researchers might test the effects of a drug mirvetuxine and omega-3 supplements. Patients are randomized into 4 groups based on drug dose and omega-3 intake, and this design compares drug doses and the supplement versus placebo efficiently. However, a key limitation is the risk of effect modification, where the effect of one intervention might change depending on the other. If, for instance, the omega-3 supplement works only with a high dose of mirvetuxine, the results could be misleading, and researchers would need to separate the groups, thus reducing statistical power. Next, we have cluster randomization. It is when we randomize groups of people instead of individuals. For example, in a trial of 120 college baseball teams, half were assigned to a spit tobacco cessation program, which significantly reduced use compared to controls. This design is useful in public health since interventions often apply to families, teams, or communities. However, the main pitfalls are that the effective sample size is smaller because members within clusters are correlated and the statistics are more complicated. Overall, it is a practical but methodologically demanding design. Next, we have the active control trials, which compare a new treatment with an existing effective one instead of a placebo, making them essential when withholding proven therapy would be unethical, such as in cancer treatment. So these trials usually test non-inferiority, checking if the new treatment is not significantly worse than standard care within a defined margin called delta. So to illustrate, imagine testing a new blood thinner against warfarin for stroke prevention. If we set a non-inferiority margin of +1 difference in stroke rate, the new drug would be considered non-inferior if its confidence interval stays below this 1% threshold. In other words, it performs closely enough to warfarin that the small difference is clinically acceptable. However, pitfalls include biocreep, where small declines in effectiveness accumulate over time, and the constancy assumption, which assumes the control treatment's effect remain unchanged. Overall, active control trials require careful margin selection and strong evidence for the control treatment to ensure medical progress doesn't compromise treatment quality. So next, we have the adaptive trial designs, which differ from traditional fixed protocols by allowing pre-planned modifications based on interim results. So for instance, in a study testing 3 doses of a new treatment for non-ulcer dyspepsia, if early findings show that only the highest dose is effective, the lower dose groups can be stopped early while continuing with the most promising dose and placebo. So these adaptations may involve changing sample size, duration, or treatment arms depending on interim data. However, adaptive designs only work well when early outcomes can reliably guide these decisions. So to prevent bias, all modification rules must be defined before the trial and reviewed by an independent monitoring board. Because multiple interim analyses increase the risk of false positive type 1 errors, adaptive trials are statistically and logistically complex, making them harder to analyze, budget, and explain in informed consent. So despite these challenges, adaptive designs are highly efficient, allowing researchers to identify optimal doses and durations more quickly and ensuring that more participants receive effective treatments, making them an important innovation in modern clinical research. Non-randomized between group designs assign participants to groups without randomization, making them prone to confounding. For instance, if doctors choose whether a patient gets bypass surgery or angioplasty, the groups may differ in ways that influence outcomes. Even with statistical adjustments, unmeasured confounders remain, which is why non-randomized studies often overestimate treatment benefits. Attempts to mimic randomization, such as assigning patients by record number or by choice, still introduce bias. Allowing choice may seem more ethical, but true ethics in research require equipoise, genuine uncertainty about which treatment is better, which randomization best preserves. In contrast, within group designs use each participant as their own control, reducing variation from factors like age, sex, or genetics. Examples include time series studies where outcomes are measured before and after an intervention, and N-of-1 trials where a single patient alternates between treatment and placebo. However, these designs lack concurrent control groups, so improvements may simply reflect learning effects, regression to the mean, or secular trends like seasonal changes. They work best when outcomes respond quickly and reversibly to treatment, strong in controlling individual differences but weak against time-related biases. So overall, while these designs are useful in certain situations, they are not sufficient when definitive and biased answers are required. So to summarize, while alternative clinical trial designs expand research possibilities beyond traditional randomized control trials, their validity depends on thoughtful design, careful control of confounding factors, and rigorous implementation, ensuring that our conclusions remain both reliable and ethical. With that, here are the references we use for the presentation, and that would be all, and thank you for listening.